Thank you so much for coming. It's really comforting to know that some of you come not for the first time. I've seen some of you many times before, and that's good to know. So today we are going back to the topic of TMJ and TMD, and I think this is very, very important topic actually, because we see fortunately or unfortunately, we see such patients in our practice who have TMD. And I want to start, my first lecture will be on TMJ anatomy and function. I think it's important to understand, how normal TMJ functions before we delve into more problematic area, into TMD. And I want to start with a quote by Jeffrey Arkeson. You cannot successfully treat dysfunction unless you understand function, he says. And he says this in his book, Temporomandibular Disorders and Occlusion. This is the 8th edition. I don't know, any one of you has read this book? Do you have this book? You have this book. Cool. So it's an indispensable source of evidence-based information, I think, on TMJ and TMD. And Jeffrey told me that actually now he's working on the 9th edition. So soon a 9th edition will be published, and it's available on Amazon. You can go and buy it from there. And I'll be quoting Jeffrey, quoting this book here and there throughout these 2 lectures. And also some of the images in my presentation are also from this book. So let's start. I want to ask and I want to answer primarily these 3 questions in my presentation, my first presentation. How does an asymptomatic TMJ look? How does a symptomatic TMJ look? And what is a TM dysfunction, temporomandibular dysfunction? So let's start with the basics. What is TMJ? We know that TMJ has 3 articulate surfaces: the condyle itself, the fossa, and the disc, right? And we know that in our body, there are either simple joints or compound joints, right? And TMJ is a compound joint. Why? Because it has more than 2, it has 3 articulate surfaces. A simple joint has 2 articulate surfaces, compound has 3. So the disc makes it a compound joint. What is a disc? What is an articulate disc? It is a fibrocartilage tissue that acts as a stress absorber and a lubricant during function. On the first picture, that's how the disc looks on mouth closed, and on the second picture, that's how the disc looks on the opening of the mouth. Sometimes it looks like this, sometimes it looks a little bit different. We'll talk about it in a while. So the articulate disc has several parts. It has a posterior band, it has an anterior band, and it has an intermediate zone, right? And an important structure when we're talking about the disc and when we're talking about TMD actually is this structure. What it is? It's retrodiscal tissues, right? And we know that they are highly vascularized and highly innervated. This is important. Okay, so that's the disc. I mentioned that it acts as a stress absorber. What kind of stress it absorbs? Where the stress comes from? Like what kind of forces it absorbs? Well, primarily it absorbs the forces from the muscles of mastication, right? And we know that there are several muscles which are very important when we are talking about TMJ. Primarily these muscles are important: masseter muscle, temporal muscle, medial pterygoid. These muscles are elevating the mandible, and this last muscle is protracting the mandible. What's the name of this muscle? Lateral pterygoid, correct. And it's attached also to the disc itself. It moves the disc forward. So ligaments, they are also important. There are several ligaments that are surrounding the TMJ, and they do not move the mandible, they do not move the disc, but their function is to limit, to restrict the movements of the muscles. There is a huge capsular ligament. It sort of encapsulates the TMJ, and it preserves the fluid inside of the synovial fluid inside of the TMJ. So it makes the condyle function well. It lubricates. This fluid lubricates the bony structures of the joint. Now, there are a couple of discal ligaments from the sides of the disc, and also there is a temporomandibular ligament. So ligaments, muscles, bony structures. How does it all function? This is the video coming from Sweden, University in Sweden, and it actually shows us how TMJ, normal TMJ functions. What we see here, we see a disc, right? It has two bands. We can clearly see the posterior and the anterior band. We see the intermediate zone in between, and we can see how this disc goes back and forth. And on the mouth opening, we can see how the retrodiscal tissues are stretching out, right? And then they're folding back into the fossa. They're stretching out, and they fold it. Now they're stretching out, and now they're folding back into the fossa. All right, so that's a normal functioning of the temporomandibular joint. An important thing over here, I highlighted it, the year 1985. Why I underlined it, why it's important. Because before that year, before mid-80s actually, TMJ could only be seen clearly post-mortem, right? Why so? Well, simply because before that time, MRI, CBCT technologies were not that developed, and only after mid-80s, we started to look at TMJ on MRI, on CBCT. Before that, it was not possible, so we didn't see TMJ structures clearly, right? But we, or dentists, speculated on these structures, despite the fact they were not able to see the condyle. Okay, so this actually leads us to this centric relation controversy, which is still a big thing, and Dr. Yakub will talk in details about CR controversy. But I want to just touch the surface about CR controversy. So there was a movement, and it was called gnathology. It started in 1920s in US. And what these people who called themselves gnathologists talked about, mainly they were preoccupied with this question: is there an ideal condyle fossa relationship, which is good, which is healthy, which presumably can treat TMD, whatever the belief was. There were many beliefs. We know that there is this glossary, the glossary of prosthodontic terms, that is considered to be the Bible of prosthodontics. And if we look at several editions, to this day there are 10 editions of this glossary. And when we look at the early editions, we see that the CR, the centric relationship, was defined as the most posterior position of the condyle inside the fossa. Then, after 1968, it was changed to the most posterior superior position of the condyle inside the fossa. Then, starting from 1987, CR was defined as the most anterior and superior position of the condyle inside the fossa. But what's important to realize? It's important to realize that all these definitions were coming, then clinicians were not able to see the condyle clearly. It was seen only post-mortem, right? They didn't have the technology to see how it actually looks like, how condyle fossa relationship actually looks like. So this leads to a lot of criticism, and that's the classic criticism of CR concept altogether. It's by Lyle Johnson, who's probably one of the most important academic orthodontists in the world currently living. He said that the progressive modification in the definition of CR has done more to eliminate centric slides than 20 years of grudging acquiescence to the precepts of gnathology. And that's beautiful, I think. So in other words, clinicians who are trying to figure out what is condyle-fossa relationship, they are actually looking pretty much as this blind man trying to define what the elephant is with their eyes closed, right? One is touching the trunk and thinks that it's a snake, another is touching the body, thinks it's a wall, so on and so forth. So it's kind of strange, right? They simply did not have a technology to look at the condyle before MRI and CBCT came about. So when it came about, we started to have studies, right? Researchers started to produce studies. Like this study. This study is done with MRI technology. This study comes from Germany. This is a study by Chirp. And again, I think Danny will talk about this study in great detail, but I will just touch the surface now. So the researchers looked at 72 asymptomatic subjects, no TMD issues. The method was MRI. They provided MRI scans of TMJs at closed jaw. And the results were such. 49% of condyles were located centrically in the center of the fossa, but 51% of condyles were in an eccentric position, either a little bit distally or a little bit anteriorly inside the fossa. All right, that's another study. This study comes actually from Brazil. This is a little bit more sophisticated studies because the authors divided the subjects into several groups according to angle classes. They said, okay, let's look at class 1 malocclusion, let's look at class 2, class 3, all of them asymptomatic. Are there any differences in condyle-fossa relationship? They look at the TMJs of many subjects. The sample is huge. You see, 30 subjects with normal occlusion, 30 subjects with class 1, 30 subjects with class 2, 30 subjects with class 3. All of them asymptomatic. And what they figured out that there was the lack of condyle centralization among all groups. Doesn't matter what class it is, there is no centralization. The condyle is not in the center of the fossa. These are my patients. These are the CBCT records of the condyles of my patients. And as you can see, the first patient over there on my right-hand side, the condyle located probably a little bit anteriorly. The one in the middle, the condyle locates in the center of the fossa. And the last condyle located kind of distally. So the question is, which of these 3 patients have a painful TMJ? What do you think? So the correct answer is none of them have any symptoms. And that's my patients. I've seen them, I treated them for at least 2 years, no symptoms over this period whatsoever. So there is no ideal position of the condyle. We know it from the studies, we know it from MRI, we know it from CBCT. But, important question to ask, but is there something that you look at and that it's completely wrong? You see something on X-ray and you understand that's wrong. Can it be such a position? Yes, it can be such a position. It's called not-seated condyle. And when you have such a non-seated condyle, it's called dual bite, right? That's basically a condyle when the mouth is open. This is one of the patients I've seen. This patient came from another doctor. Another doctor called herself gnathologist, and she gave to this young lady a splint to wear 24/7 for 6 months. And that's the result. The condyle is outside of the fossa. That's wrong. We are talking, where the condyle should be. At least it should be in the fossa. That's it. When the condyle is outside of the fossa, that's wrong. But, some gnathologists, for some reason, believe that the condyle should be outside. That's something I cannot agree with, right? So what about the disc? We talked about the bony structures, right? Where the condyle should be positioned in the fossa. Let's talk about the disc, where the disc should be. Where is the disc in asymptomatic patients? So that's the study, a classic study, one of the first, MRI study from 1996. So the subjects of this study were 82 asymptomatic volunteers and 263 patients with TMJ symptoms. So the method was MRI of TMJ, and here are the results. The authors found that disc displacement was observed in 33% of the asymptomatic volunteers And yes, the incidence of disc displacement was more common in symptomatic volunteers. 84% of symptomatic patients had disc displacement, but anyway, 33% is a huge number. What this study tells us? This study tells us that every third asymptomatic patient has a disc displacement. So meaning every third patient you treat, at least every third patient you treat, has anterior displaced disc. And this raises the question, is this displacement a dysfunction? Is it a dysfunction? So let's consult Britannica Dictionary. According to Britannica Dictionary, dysfunction is the state of being when the body is unable to function in a normal way, right? So what prevents normal functioning? What prevents us from chewing, swallowing, and speaking? What prevents us from that? Well, there are only two things, pain and limited opening. If there is a pain, we cannot chew, swallow, and speak, right? The click does not prevent us from normal life. So clicking is not a dysfunction. But, important question you may probably ask, but can it progress into a dysfunction? Do you have any ideas on that? Can it progress? Can clicking progress into dysfunction? Actually, this question was studied a lot, and the first person who studied it, sorry, we don't have the first letter, but it's Chuck Green. Chuck Green looked at this question back in 1988. They studied long-term status of TMJ clicking in patients with myofascial pain and dysfunction. We had similar studies from 90s, like this study from Kononen. Does clicking adolescence lead to painful temporal mandibular joint locking? And we had more recent studies like this by Kalaikova from Netherlands, 2-year natural course of anterior disc displacement with reduction. So, what do these studies tell us? In all of these studies, authors looked at clicking patients, right? Patients who had some clicking. And they monitored these patients for a prolonged period of time, for like 2 years, in some studies more than 2 years. And what they found, can clicking progress into a dysfunction? All these studies are telling us that on average, there is 8% chance of progression. 8% chance. Is it significant? I'm not sure. I think any condition can progress into any condition over the years with 8% chance. Okay. Where do pain and limited opening come from? Important question to raise, right? We have a TMD, temporomandibular disorder. And we know that all TMDs could be divided by either muscular disorders or intercapsular disorders, right? So pain comes either from the muscles of mastication or from issues inside the capsule of the TMJ. What kind of intercapsular disorders we are talking about? Well, internal derangements, right? We already said that sometimes this displacement could be associated with TMD, sometimes. Idiopathic condylar resorption, what it is? No one knows. We don't know where it comes from because it's idiopathic, but we know that it's very aggressive, very fast onset of the progression, and you see the condyle melting like very, very fast. And there is also a thing called rheumatoid arthritis. What is rheumatoid arthritis? It is a autoimmune condition when the immune system of the body is working against the body itself. So I think it's crazy if someone tries to tackle autoimmune system with a piece of plastic, but we still have such theories that a piece of plastic between the teeth can cure autoimmune disease like rheumatoid arthritis. Anyway, very often intercapsular disorders and muscular disorders could be seen in the same patients, right? Let's talk a little bit about disc displacements. We know that there are a couple of types of disc displacement, right? What are they? Like 2 types of disc displacement, 2 types of anterior disc displacement. Yeah, with and without reduction. What is a disc displacement with reduction? Disc displacement with reduction is a condition when the disc is displaced anteriorly in front of the condyle, but then on mouth opening, it clicks back, it pops back into its former position. It looks like this. Let's see how it looks. Again, the same study from Sweden, and we see then the mouth is getting opened. You see the disc clicks back. Now it's getting closed and it pops anteriorly again. Now it opens, mouth is opening, and this is a reduction. The disc pops back. Okay. Another type of disc displacement is disc displacement without reduction, or complete lock, you can call it. It is when the disc is displaced anteriorly and it's not reducing back at its former place, right? It's stuck anteriorly to the condyle during mouth opening, during mouth closing. Okay, let's look at how it looks. You see the disc stuck anteriorly to the condyle, and it's not getting reduced back. It's not getting reduced back. It's here. This is the disc. Important question to raise, probably the most important in my presentation, so pay attention. Why some disc displacement are painful and some are not? So you have a disc displaced anteriorly, right? I already mentioned that our TMJ has 3 articular surfaces, condyle, disc, and fossa, but all of them are composed of avascular, non-innervated fibrous tissues, meaning there are no nerves in the condyle, there are no nerves in the fossa, there are no nerves in the disc, right? So where the pain comes from, why some disc displacement are painful and some are not. So all the pain comes from here, right? Retrodiscal tissues. They are highly vascularized, they are highly innervated. A very important thing what we know about these tissues is that they have a great tendency to convert into something called a fibrous pseudodisc. In other words, this is an adaptation, a natural adaptation. Our condyles are so adaptive, they can adapt, and these retrodiscal tissues may turn from highly vascularized, from highly innervated into simply a fibrous piece of tissue, right? Without any nerves. But when this adaptation will not take place, when there is a lot of emotional stress, which causes bruxism, when the muscles are tight, then there is increased activity of masticatory muscles, and such patients has bruxism, clenching, so on and so forth. If there is an overloading of these retrodiscal tissues, there will be no adaptation whatsoever. What is an adaptation, right? Let's go and look at semantics of the word. Adaptation is a change in a plant or animal that makes it better able to live in a particular place or situation. So our situation is that the disc is displaced and all the loading from the muscles are actually in the area of retrodiscal tissues. So how do we know that these tissues can adapt? Well, we know it from the studies, right? For instance, this MRI study, it shows us that there is a decreased MRI signal from retrodiscal tissues in subjects with anteriorly displaced discs. And we know it from post-mortem studies, like this study. 2.5 times increase in fibroblasts and retrodiscal tissues in subjects with displaced disc, right? This is a histological section, a histological slice of a dead individual with a displaced, anterior displaced disc without reduction. And you can see that, these fibrous retrodiscal tissues are over here, and the disc is located anteriorly, but the retrodiscal tissues, they already had been adapted to this new environment, to this new position. Okay, so let's talk a little bit about forces of mastication. We touched upon bruxism, but let's talk about normal forces of mastication. So Jeffrey Okeson says in his book that the lever system of the mandible can be compared to a nutcracker, right? Like this nutcracker. not this nutcracker, actually this nutcracker. So, what we can see here, imagine these are the jaws, right? So, what does the hand represent? What does the hand represent? The hand represents the muscles, right? The forces are coming from the masticatory muscles. Over here, like the pliers are our jaws with teeth, right? So the loading from the muscles are coming on the teeth. And also when we're biting on something like this nut, for instance, the center of rotation will be at the hinge, or if we're talking about our body, at the TMJ. So that's how it works. An important thing to realize, the amount of loading that can be generated between the teeth depends on the distance from the TMJ, right? We can chew, we can bite on a cherry if it's located anteriorly, but we cannot crack a nut, right? To crack a nut, what should we do? We should place a nut to our posterior teeth because more loading will be generated. Much more force can be generated on the posterior teeth than on the anterior teeth, correct? And actually the first person who compared our jaws to a class-free lever, this mechanism called class-free lever in physics, was this guy from North Carolina. He was a dentist. His name was William Hilander. So he wrote this article in 1974. So he said in his article, the muscle force is divided between bite force in the teeth and reaction force at the mandibular condyle. So basically what he says the loading not only located over here, like where our teeth are, but the loading actually comes to the joint. And next he says, posterior tooth loss would result in greater reaction force at the mandibular condyles, right? So in other words, he says that when a patient does not have many posterior teeth, there will be increased loading on the TMJ. This raises a question. Does the lack of posterior support always lead to TMJ? Well, we as orthodontists, I'm sure many of you here are practicing orthodontists, have been practicing for many years, right? And we know from our clinical experience that a patient can have a lot of missing teeth, but there will be no TMJ signs. Are you with me on that? Do you agree? We also know that there may be a posterior Caesar bite, but there will be no TMJ signs at all. We also know that there might be some improperly made crowns like this, again, a significant lack of posterior support, but again, no TMJ symptoms. Do you agree with me or not? So, no pain, no limited opening in all of these patients, and in many more. I just decided to put this free as the most significant visual representations of this. Okay, lack of posterior support. It's written lack of posterior support. And TMJ. Is a lack of posterior support a great risk factor for TMJ? Well, I just told you my personal belief, but let's look at the evidence. Let's look at the science. So we had a lot of papers on that. Pollinger was one of the first who produced a paper on that, and this paper is quoted many times in Ockeson's book. What he found, occlusion cannot be considered the unique or dominant factor in TMJ. However, also important is that risk could be increased if more than 5 posterior teeth are missed. Like 5 posterior teeth missing, that's a terrible thing, but yeah, it could be. Bales, another researcher, he published this paper in '94 in Canadian journal. Little evidence was found to support occlusal factors in TMJ. And again, I'm just highlighting the most famous papers, but there are many more on that issue. And there is a more recent paper. This is actually a systematic review from 2023. There is no evidence to support the association between one or more tooth loss and the presence of TMJ. Okay, so we know that lack of posterior support is not a great risk factor to TMJ. What about disc displacement? I already told you that almost every third patient of yours, asymptomatic patient, will have a displacement of the disc, right? We have more recent studies on this issue, like this study from TERP, more or less the same number, 25% of asymptomatic subjects have displaced disc. So again, this displacement is not a great risk factor. What about bruxism? Is bruxism a great risk factor for TMD? Not really. We have studies telling us that TMD pain is not related to the intensity of sleep bruxism. We have studies telling us that myofascial pain cannot be explained just by cause and effect relation between sleep bruxism and myofascial pain. So, but let's imagine such a patient like this. This patient has a displaced disc, right? A displaced disc. This patient has a bruxism, right? Very high amount of force coming from the muscles. And this patient also does not have posterior support, nothing to accommodate this loading of retrodiscal tissues, the loading coming from extreme activity of masticator muscles. What will happen to such a patient? Yes, such a patient may develop a TMD. Why? Because, our adaptive mechanism may crack under all these, risk factors coming together. That's why we're saying that TMD is always multifactorial in nature, and we have to exercise our logic. We have to, look at all the symptoms. We have to look at all the documentation, clinical, radiographical, to figure out, how all of these factors relate in each particular individual. We can't say, oh, you have bruxism, you'll develop TMD, or you have one or two or three teeth missing, you'll develop TMD. That's not true. We know that's not true from the studies. But, if all these factors are coming together, then, the adaptive capabilities of the body may finally, end. So, how shall we manage TMDs? How shall we manage TMDs as orthodontists? Tell you in the next lecture. Okay, so just a take-home message, a couple of them. Radiographically, an asymptomatic and a symptomatic TMJ may look exactly the same. We don't look at radiographs to find, TMD. Important. TM dysfunction is characterized by pain or limited opening, either by pain or by limited opening. It's not always, maybe sometimes, but it's not always expressed in morphological changes of the TMJ structures, okay? Or the same message, in other words, more laconically by Chuck Green, TMD is reported, it's not discovered, okay? You do not discover TMD on your radiographic image. You don't see a radiographic image and say, it's TMD. No, TMD is reported. A patient comes to you and he or she tells you the symptoms. That's all by now. I think I'm on time.
Yeah, sure.
Cool.
We have Åkesson in...
We have Dr. Åkesson, we have a legend joining us in 15 minutes. And now I encourage you to go and have a coffee, snacks, and have fun. Thank you.
See you in 15 minutes.